everyone. I hope everyone's doing well tonight. Welcome to our case of the week. I am Caro, the Credentialing and Education Coordinator. We'll be answering any questions throughout this presentation as we go. And now I'd like to introduce our speaker, Dr. Polly Michaels.
Hey, and good evening. Can everybody hear me? Are you good? Are we good, Kara?
Yes, we can hear you.
Okay. So I am honored to be doing this tonight, and I am presenting something that I think we all deal with, especially today where we're in the era of predictable implants, and that is the loss of an anterior FPD or even part of a roundhouse FPD. And in my practice, at least in the last 3 years, I have added the dynamic guided navigation to my equipment. This is my dad and my mom. My dad actually passed away in July of this year, and these babies that were 16 days old are 16 years old today. But the reason I put this up here is because without the opportunities that these two provided for me, I would not be able to do what I'm doing right now. I graduated in 1998 from the Medical College of Georgia. I placed my first implant in 2000. I have practiced in Washington State, Oklahoma, Alaska, Colorado, and Florida. And the reason for all that moving around is I wanted to live different places, and I put in 8 years in the Commissioned Corps. I completed a 2-year hospital-based AGPR in 2002, and then decided I didn't know anything after a few years and wanted to go back and took a maxi course in 2011 to kind of catch up because we know everything changes. I've now for the last 10 years been in private practice in Weeki Wachee, Florida. So when I think about what we all do on a daily basis, placing implants and working with people, one of the things that I tend to ask is, why wouldn't you want to shoot the Q-tip? And I ask myself that. For any of you guys who may have seen in the early, I think it was 2010, the show called Top Shot, they did a lot of different tricks and repeated some of the things like the Annie Oakley shot, things like that. And one of the trick shots that they completed that caught my eye was from 25 feet away, a gentleman using a little 22 shot the top off of the Q-tip. It's been repeated many times. And if you Google it, you'll get, for Top Shot on the History Channel, you'll get about 74 million hits. And for the videos that have been done, you'll get about 4 million. But it's very detailed. And I think that that's what we're trying to achieve. We want the best detail and the most precision that we can get. So this right here is my case, and this is Mila. And Mila walked in, and I'm sure every single one of you has seen something like this, where it was just one canine that was holding in the entirety of the anterior aspect of an FPD that's been there for a while. She had no posterior support on this side. When she first walked in, she looked like this, and this has been glued on, super glued, she said 5 times. And as you can tell, she's lost lip support in that area, root canal on this tooth. But I think that's a pretty familiar looking case to us. This is the ending, and this is what we ended up with, and we gave her support back. But this is also still a provisional. We are working on the posterior teeth over here. It's a little blurry picture, but you can see how we got the support back. To move forward with this precision, I start thinking about the things that we can do now as opposed to what we could do a long time ago. And if you look at medicine, whenever you replaced anything, they had all sorts of crazy things that you could utilize. And sometimes then you started to get something that maybe functioned a little bit more like, say, that missing leg, but didn't really look like it. And then maybe one that looked like it, but still really doesn't function like it, to now where people who are missing their legs or their feet can be on Dancing with the Stars, and they have dancing shoes and climbing shoes and running shoes and, you know, all sorts of neat things. And now even starting to get to the point where we're using some of the messaging between the brain and some of the bionics in these prosthetic legs. So I think that's pretty cool. And we've done some of the same things in dentistry, where we started off, you know, trying to make it look like teeth and got a little bit better to where we got to, man, these really do look like teeth, but they don't function like teeth. And then we got to the bridge, which nobody can really tell the difference between the natural teeth and the bridge, but we are utilizing other teeth. And we do see some problems, obviously, with cleansability to where we have implants. Well, the same thing has happened in our diagnostics. And it always bothered me that our diagnostics, we could get so detailed, but we couldn't carry it to the mouth. So when I started, we were bone sounding. Moved into having panos, and then to handle the distortion of the panoramic radiographs, we would use the BBs, and then coordinating with hospitals, trying to get your patients in with the gutta percha right in the right place and reading it and scheduling the times. That was a real pain in the ass, but it gave you a lot of information, to now where we have our own CBCTs that really are developed for us and allow us to have a lot of detail. Unfortunately, once I plan on this, it really bothered me that I'd run over to the mouth and use my perio probe, which is certainly not as detailed as my CBCT. And I wouldn't be able to take that precision in my planning all the way to the mouth. So I'm a more of a traditional method person when you think of construction. There's some people that do the design build, which they have the concept and they kind of design a little bit along the way. Everything happens to the final construction. With me, I'm belt and suspenders. I want to plan as much as I possibly can, without paralysis or redundancy. And I want to utilize that to make sure that the final construction is what I planned it to be. So I'm pretty excited when I utilize my dynamic guided navigation. Now, I've been placing implants for 20 years, and I only show this because this is what I did freehand. So I don't think that I did too crappy of a job. I think that I did okay. But these are cases that are 10 to 15 years old. And it wasn't because I didn't do a good job or was concerned about my parallelism or things that I added this. It was because I wanted to take the detail of the planning and bring it to the mouth. So for those of you who know what the X-Guide is or the X-Nav, this part will be familiar. For those of you who don't, I'm going to show a quick little video of how I utilize this machine. And I'll probably pause it once just to show you, but it's not very long at all. So when you're looking at this, you can see this orange area, and you can see it's right on the facial of the tooth. When you use the X-Nav, you are not looking in the mouth. You are looking at this screen. Now I've blown it up so you can see it. You have 3 different planes right here. And right now what I'm doing is a system check to make sure that what I'm seeing in the mouth is actually what's going on the screen. Then I can trust the machinery. I can trust my navigation. So you'll see me tap here, here, and on the lingual. So incisal and lingual, just to make sure that everything is correct. And then we will actually show the one osteotomy burr so that you can see what that looks like.
Facial surface.
So there's the facial.
Recording on the GoPro.
And you see I'm kind of looking down for a second to move my burr tip. There's the incisal.
And on the lingual.
And there's the lingual.
Perfectly on the
so now I'm going to come over here. I'm going to basically put it where I would like to place the implant. And I'm trying to stay within 0 degrees. I mean, that's the goal. And you can see where you are in every plane. So you can actually watch me. And this is my depth. And you'll see it bounce a little bit because you still have to have that nice surgical technique where you're not heating up the bone. You're taking care to eliminate any kind of heat. You're keeping irrigation, but I'm staying pretty much on. And then once you get to the depth that turns green, you have a little bit of a deviation, and that's how the system pretty much works. I find that I'm able to be very precise in 3D in real time. I love it because it's minimally invasive. I can do flapless more predictably. I minimize the number of surgeries that I do because I do more bone manipulation. I decrease my grafting because I use the bone that's already there, the use of native bone. But the surgeon is still in full control. And I will emphasize this many times. I have found that it is an enhancement of an excellent surgical technique. It is not something to replace an excellent surgical technique. Other little things that I have found is that my back is straight. If you look at when I'm performing my surgeries, I can work lefty or righty. I've never done that. In 20 years of practice, I've never worked lefty. And I place most of my upper left implants lefty now. And I have this mix of radiographic and 3D imaging. So that gives you a little bit of a background on the dynamic guided navigation that I use. And I'm going to go right now and get back to the case unless anybody has any questions so far. So this is what we started with. And I'll get a little bit closer. You can see that there's actually a vertical root fracture here. And you can see that it's been this way for a while. And this is, of course, where she had it super glued. So we cleaned that up just a little bit. Our choice is, because she's got a wedding, of course. It's amazing how many times that's actually the truth. But we could leave it as is for now. That's when she walked in with it super glued, and hope for the best. We can remove it and make a temporary treatment partial for the wedding. We can remove it and attempt to re-cement. Maybe I could put a post in there. I could try something like that. Immediate placement of implants and provisional restorations. After the scan, we found out that was not really a good option. You could also add mini implants to this as provisional implants, and you could probably put something on there because I did have more vertical height than I had width. This was the option that we chose to do for the wedding, and then to come back and do a more complete, predictable, long-lasting treatment plan. But that way, none of this was going to fall apart in the middle of a wedding. Whenever I take on cases like this, I always do a huge report, and it is somewhat of a pain. We've gotten pretty good at it, pretty proficient at it now, but I've never had a time where I didn't learn something. I think that I do a pretty good job of being detailed. I think that I try to look at everything, but going through this is a list of anything that really could affect at least the majority of things, probably 90% of things that I believe could affect my outcome and the way that I would plan. So one of the things that we did emphasize with her is that she fully understands that the anterior teeth will not survive without posterior support. So that is part of the plan. So removing number 11, placing implants in 6, 8, or 9, wherever I want it, and 11, fabricating FPD, place implants in 12 and 14 with a sinusog and fabricating FPD. We had another option there, but we decided to hang out with this one. So let me move on, see what my next one is. Here's some more of that report. And you can just see, we go through everything: profile contours, biotype, speech. Did they have any speech impediments before? The alveolar mucosa, skeletal profile. There's always something that I find when I'm looking through this that I really wouldn't have thought of. So here are her initial radiographic findings. You can see the split very easily there. And that's just the rest of that. So that's what I showed you at the beginning. And what I'm going to show you now is the pre-ops of the CBCT scan in all angles. And this is for the number 6 area. So you guys will get to see, you've probably already seen that there's a narrow ridge. I'll go back one just for that. But anybody who wasn't looking at that, it looks pretty narrow, at least there. And it is. So we're over here. Here it is in every view. And you can see I'm locating that in the same area as where I plan to place my implant. I put cotton rolls in the vestibule. It helps me a lot, and I can show you one in a second where you can actually see the thinner bone that's on the side, especially when there's a tooth there. I would prefer it be a little bit farther up, but we find it a little bit hard to walk from your clinical room over to the CBCT. It tends to fall most of the time. So that's what I get. But here we are in the area of number 9. This is our pre-op for number 9. And then here we are at number 11 where that tooth is. And this is where it helps. You can see that cotton roll there, and you can tell we actually do have buccal plate over here. So I was real happy to see that. And then here's 12 and 14. So 12 is a godsend. I don't think that there's really anything that, I mean, if I screw that up, I'm really having a bad day. I think that one will be something that will be nice and stable and wonderful. And over here, we have a little bit of the opposite. And the reason I say that, it's not a horrible thing. I've got great width and I've got really thick bone in 2 areas. But if I want to deal with this area right here, I'm going to have to go through either some pretty thick bone here or thick bone here. Many ways you can do that, and we will address it. but I'm going to focus on the anterior right now. I just wanted to show you those two as we will be heading there soon with our patient. So I went ahead and I planned, this is my pre-grafting plan because I am going to graft, and some of you will agree with what I do and some of you will not, but I'm happy with the result and I think that she's well served. This right here is the planning in the X guide, which is really cool because I placed this one based on our tooth here, and I can simply hit mirror for the one on the opposing side. And it will actually, on the contralateral side, mirror that angle. Canines are the most difficult to plan, in my opinion, because they're at the corner, you're turning things around, and you can't see the angles as well as you would like to. So, but there's my planning. And as you can see, this one was a 3-2 that I was planning. I ended up placing 3 7s, 3 7 by 11 5s, but this is a 3-2. And it obviously is outside the cortical aspect of the bone. So we've got to do something. So here are my surgeries. At least this is the first surgery. And I went ahead and I reflected a very large flap, full thickness all the way across, both on palatal and buccal. I forgot to remove this little area at first. And once I had flapped it, I wasn't about to do it. So that's going to stay until after the next surgery or after the post-ops at least. Here's where I'm showing the bone and the width of it. I also have started a little osteotomy over here. I love these instruments. Some of you may have heard of them. Some of you may not have. They're by a company called Surgeon's Hands, and they really have helped me manipulate bone very easily. They're meant for a surgeon who likes to manipulate the bone that is there and caters to that. This is where you can see the vertical root fracture and where the tooth has been broken off. This is another one of those instruments, and actually I'll have a clearer picture of it in the second surgery, but it has almost like a little osteotome with a 15 blade that you can attach to it with a thumb screw that's down here so that I can score my bone, can flip it around and score it on the other side. And then mesiodistally, when I'm manipulating the bone, I actually split it where I want to. I don't end up breaking things off, which I really like. So here are a couple of my starting osteotomies. And you can see very easily that I have some fractures in here. This doesn't bother me. I have, and I don't know how many of you have experience with Tatum D implants, but I've placed some of those and they've been very successful for me. And one of the things that you do, now you don't reflect tissue because of course Tatum is all about, and we all should be, having a good blood supply. And he does it flapless. So when you place those, you actually though crush the buccal plate, and the periosteum is what keeps that blood supply there. Now I don't have the periosteum here, but I have not displaced the bone fragments from each other. They are still connected. I really just have not had any issues with this, so it doesn't bother me when I have that. If I have one that is sticking out or there's a real difference between where the fracture line is, one piece to the other, of course that's an issue, but I really just don't have a problem with that. So we'll move on through. You can see I'm getting things just a little bit larger. And this instrument actually has a cutting blade. I can't remember if it's a 180 degrees, but you know how you're always pushed towards the buccal? This has a cutting blade that only cuts into the palatal. So by hand, turning it left and right, you're actually going to compress on the buccal and cut on the palatal. That's another reason I tell you, it's designed for surgeons who like to manipulate bone. Here's me removing this tooth. Now, I didn't show that I used some periotomes previously, just Salvin periotomes to get down into that ligament and loosen that tooth. And I really want to save the buccal plate. And we did. So I was pretty happy with that. I did not do it simply with the periotomes. If you notice, I created my own little fenestration down here, right at the root tip, and just used a little root tip pick to help me lift that up so that I wasn't moving on that bone over there. I'm placing a bone graft. This is actually in the extraction site, but it's a larger particle bone graft. To be honest with you, I stock two different types of bone for the most part. I do have a synthetic and I do have some beta TCP for my sinusoids, but for onlay grafting or socket grafting, if you want to call it that, I use either Rocky Mountain 50/50 corticocancellus, but I use the large particle size, or I use Salvin's corticocancellus 50/50, and it's got a smaller particle size. I honestly don't care which one the girls hand me because I get the same results with both, unless I have some really, really thin biotype, and then these particles are a little bit too large. I've placed a membrane, a PRF membrane over here, and I like to do that before my onlay graft. There it is, so that it's already there. I'm not trying to tuck it underneath the graft. It's already laying against the periosteum. And I have scored the periosteum as well to allow myself then to close over this big, this large amount of bone that I have placed. And there's the graft. So I'm going to go ahead and place more membranes, PRF membranes across it. This is where the socket was. And then I'll go ahead and start suturing. Now, I haven't done anything with the other side, and we could go ahead and do something like that. But I find when I do that, I'm not talented enough to keep this area from sliding around and moving, and the graft goes in different places and the membrane's not where I started with it. And maybe I'm even pulling the tissue over and sliding that flap without meaning to. So I'm going to go ahead and suture this side so that I know it's held in place, and then I'll move on to the other side. Every time that I do this, I shouldn't say every time because none of us do things every time, but majority of the time, my routine is that I use mattress sutures and I use interlocking continuous. I do whichever one first that I feel like tacks everything down the best. And then I come back and do the other one. And that gives me where I really don't have a lot of tension. And I tend to be able to pull things very close and not have tension. So here I am on the other side, and I'm tucking the PRF in before I place the onlay graft. You can see where my osteotomy has been started. And this always helps me when I come back. That really bothers me. I'll get that later though. And again, here's the other side where I was handed the other type of bone. I think it's pretty cool that I'm sharing this case. I didn't realize that this was what had gone on until I started looking at the slides, but I think it's kind of neat because you'll get to see the results on both sides. So I packed that in there, again, placed my membranes, and here I am going to do the suturing. And same thing. Obviously, I'm going to do the mattress sutures here first, and then I will do the continuous. And you can see how loose they get. And I think I got pretty good closure. Not so happy with this guy over here, but we turned out okay. So there it is. That's how I'm leaving her for this period of time. And she healed for 3 months-ish, right around there. So here's our post-grafting. So we're moving on. We've waited 3 months. Those grafts have healed. And I'm going to show you each site again. So here we go. This is our number 6 site. Here's our number 9 site with the grafting that we got there. And then here is our number 11 site, starting to look like number 12 over there. So I went ahead and I went back and planned again. And now I can actually fit, and these, like I said, these are 3/7s. I can fit them where I want them to go. So I'm going to go ahead and show you the second surgery. So this is what it looked like when I opened again. And I did complete a full thickness flap, and just as large as the first one. Here's the instrument I was telling you about. You can see the thumb screw on this one. And you can see how I'm scoring the bone on this side. And then I flip it around and score it on the other side. So here's a little view of what we got clinically. And you can see I finally got this out, which just makes me happy. Okay, placing the PRF again, because I actually do graft again, not on every case, but on this one I did. And here we are with osteotomy and placing the implant. That looks like a driver right there. So there are a couple of the implants in place, placing the membranes again. And for my PRF, I'm not fancy. I may become fancy, but I'm not fancy right now. I simply take the blood, no chemicals, no anticoagulants, no anything. I spin it in actually a centrifuge I purchased used from a hospital lab. Can almost hear some of the comments now, but in any case, and then I just compress it. I'm not using it necessarily for the viable cells. I'm not using it for a lot of the growth factors because there's so much that's going on right now and so many things that are coming out that, you know, I've got to look at it again. It's kind of like when I went back to the Maxi course after 10 years, it's time again for me to learn even more. But I'm using it because it's something the body likes. And it's something that has the consistency and longevity that I want it to have. So here are the implants. Here's the grafting, and looks like I used the 50/50 Salvin on this particular one. Again, there we are. And the suturing. So more membranes. And you can see I've got tension right here. There's a significant amount of tension. And I did score the periosteum again and tried to do what I could, but I've got tension. So I did go back and place more sutures. And this was what I could get. And you can see how loose those original sutures got when I went back to do that. So I have really good luck with that. That is something that I haven't been doing, but for maybe 6 or 7 years, but it's helped me out a lot. So here we are after placement, and you can see how I manipulated the bone. I'll blow it up for you so you can see. Here's the area number 6. There's 9. And there's 11. So you can see that. And basically with the navigation, where I put it is where it ends up. It's really something very cool. And like I said, I didn't do too shoddy before I had that, but now I can engage, say, the lingual cortical plate if I want to, where there's an undercut. I can engage the floor of the antrum, and I have pictures of this without going through, looking at it 3-dimensionally. So it's a pretty cool thing. I enjoy using it. So just to compare, so you can see it all along, this is 6 pre-op, 6 post-graft, 6 post-implant, and then here we are a year later. And I think we've maintained bow height and everything there. So I'm pretty happy with it. I'm not sure why that one's coming up. So the reveal over there, but here is the pre-op, post-graft, post-implant, number 9 at 1 year. And I didn't expose her to another scan. I had done enough scans on her. I don't always do that, but I did this time. So here we are with 11. And this one, I believe that ended up a little bit more anteriorly, but we did move a significant amount of bone. And when I changed this around, it actually looked thicker, but I like this view because you can see exactly where that is. But there's 1 year. And after all of the surgeries and everything, here are our custom abutments. And her tissue healing. And then our provisional restoration as we start to work on this posterior on the other side. So there is Miss Mila, as we showed in the beginning. And when I look at it, I say, hey, everything's still evolving. As far as the navigation, they've already developed some less cumbersome hardware. I still like the osteotomes, and the surgeon hands instruments are good for me. I like that. Everything will be exactly where you planned it when you use dynamic guided navigation. And I will tell you, it took me a little while to learn that my planning was not quite as good as I thought it was. It slowed me down a little bit at first. Next step, I would love to see us actually grow some real teeth. And finally, I will end on, why wouldn't you want to shoot the Q-tip? Why wouldn't you want to be that precise? And that is my presentation. I hope that it was helpful and maybe you picked something out of it. Thanks for letting me present tonight.
Thank you again, Dr. Michaels. If anyone has any questions, we'll probably give it a minute.
No problem.
I don't see anyone with any questions yet, but if anyone wants to submit any, we do have some comments that say, bravo, thank you for a great presentation from James, and Dr. William Ingram says, yay, Polly. So it looks like that's what we've got. But thank you again, Dr. Michaels, for sharing your case with us tonight. And we hope to have you again. Stay safe, everyone, and have a good night.
Thank you all.